Is Amber wants you to go in the bathroom or somewhere and videotape yourself saying your name. So when your name is called out on Saturday's white coat ceremony, Nandini is not pronounced Nandini. Although I did hear on the BBC news report this morning, they were talking about Adidas, and they pronounce it Adidas.
Adidas.
Which I thought was kind of interesting. The other thing is, I'm going to pass it, I'm just going to start this piece of paper right here. If you will put the number of people you have planning on coming to the white coat ceremony. If it's zero, don't put anything. Just give me a wag, okay? Just give me a wag here.
Too far, Larry.
So, I know that Macy has to pay people to come. But
You're right.
if you think,
I'll be there for you. Thank you, guys. I have 36 friends that'll be there.
So much.
35. 35. The whole room.
She was
any questions, you're gonna have a little thing on the white coat ceremony, I think Wednesday, they're gonna, somebody's gonna come down and tell you how it's gonna go, or how we think it's gonna go. No, don't write your name, just give me a number.
If your name is Bradley Brown, do you need to record?
No,
Okay.
just put, and don't count yourself, okay? All right, so what we're going to do this afternoon, we're going to talk about the foregut. And then tomorrow, we'll talk about the mid and hindgut. And you'll see how this plays out here in just a minute. Today's dissection, it doesn't really take that long, but you got to get after it. We're going to follow some blood vessels out to the foregut. And we're going to take a look at what is going into and out of the liver. Also, you want to open up the stomach just to see inside. It's kind of cool. And the pancreas, the duct system is important to understand that. Okay? So before we get into the foregut, I'm going to give you a little embryology. Just because it's easier to understand how the GI tract is laid out if you understand how it got there. First of all, you have about 30 feet of intestines from your mouth to your anus. Most of that you got to get in your GI tract. So it's going to, in order to get all of that in there, it's going to involve a series of foldings to get all the pipes in there. So, before we get into the foldings, let me just get you acclimated to a couple of terms. When you were 3 weeks after fertilization, you were a flat disc. During the 4th week, the flat disc started to fold in from the side and fold in from the top to produce, by the end of the 5th week, that structure that looks like that. And you were about the size of a pinhead at this time. So that's about at the end of week 5. Now, if you do a sagittal section through that embryo there, this is what you see. We're going to focus on the GI tract here. So imagine you have a gut tube that goes from the oral cavity down to what will eventually be your anus down here. At this point, it's a cloaca. Your urinary tract and your GI tract are all the same. You're like a bird. It's not until later that they divide off and separate those two systems. But we're not really that concerned with what goes on down here at the end. By the way, I like your hair. Everybody like our hair? Right? Okay. What we're going to do is we're going to look at the aorta here. The aorta, coming down the posterior wall, develops three arteries, three unpaired arteries. And those three unpaired arteries are first the celiac artery, the superior mesenteric, and the inferior mesenteric artery. Those three arteries supply from top down the foregut, the midgut, and the hindgut. The way it's set up is really kind of easy. So what we're going to focus on today is everything supplied by the celiac artery. Now, when you were a little bitty embryo, and this gut tube developed, here was your outside, and then the inside, whoops, the gut tube was suspended by these structures here in the middle. So it's kind of like the heart and the lungs, you know, we've got a visceral layer and then a parietal layer. The same thing with the GI tract. Now, so we have one end of it is, we'll call it the dorsal. The other one, we'll call it the ventral. And we're going to call this that wraps around the GI tract the mesentery. So you have a dorsal mesentery and a ventral mesentery. Now, the ventral mesentery, once you get past the foregut, goes away. So it's only foregut structures that have a ventral mesentery. Most everything still has a dorsal mesentery, and I'll address this later on. But the point is, the ventral mesentery, once you get past the foregut, or once you get past the vessels, the structures that are supplied by the celiac trunk, there's no more ventral mesentery. And that's what you see right here. Here's the dorsum of the little bug. Here's the dorsal mesentery here. Everything is connected to the dorsal wall. Here's the ventral mesentery here, coming off of the stomach, what will be the stomach, attaching to the ventral wall. And then once you get past the celiac trunk, there's no more ventral mesentery. Kind of cool. All right, so we got this gut tube like that. And this is, we'll say this is going to be the stomach. It's just a tube. Then you start getting these diverticula that grow off of the tube. So these diverticula will grow off of the tube into the mesentery. And once they grow in there, they'll start branching. Now they're covered with mesentery. Right? These things that branch off of the foregut tube go to become the liver, the gallbladder, and the pancreas. And all they are is diverticuli that grow off this foregut tube. And once they grow out, they start branching to give you all the ducts of the pancreas and all the the cells at the ends of the ducts to secrete the pancreatic juices. Same thing with the liver; it branches 1 billion times to give you a liver. With the gall bag, it's just a bag. It buds out and it grows to be a bag. So those three structures come off of the foregut. The gallbladder, the liver, and the pancreas. Actually, the pancreas does something really screwy. It just, one pancreatic bud grows off ventrally, and one pancreatic bud grows off dorsally. They're not at the same height. And then what happens is one bud swings around and fuses with another bud. So you only have one pancreas. But look at the shape. Here's the two pancreatic buds. One swings around and fuses to the other. Therefore, the pancreas, as you're going to see in a minute, has a shape that looks like, well, looks like that. One bud has fused to the other. Looks like that. Okay? That's why the pancreas is the shape it is. But it's a foregut structure. Right? Now, off of the, couple of little remnants here, is off of the GI tract. This is going to be the intestines right here, because that's supplied by the superior mesenteric artery. This is going to be your small bowel, mostly. Small bowel. Off the end of that is this thing right here called the yolk stalk. It's going to attach to the yolk sac, which is out here in the placenta. If you were a bird, that'd mean a whole lot to you. As a human, not so much. Okay? Actually, if you were a sea turtle, here's the thing about sea turtles, is that, you know, they, the moms bury them, it's like 36 inches, they've done studies how deep it is, 36 inches down. So when a sea turtle hatches, it still has its yolk sac attached to it. It takes that sea turtle a couple of days to get to the surface, and by the time it gets to the surface, it's used up his yolk sac, and now he's good to go, right? So they were doing these breeding programs where they were taking all these turtles, and they would be born in a nest, you know, they'd create some kind of pillow or something, and it had these little yolk sacs on them, but a bunch of them would die. The mortality was huge, like 90%. Until they figured out, wait a minute, why don't we bury them 36 inches down in the sand, and now they have a survival of 96%. It's crazy. Just in case you're into your turtle biology. Okay? What were we talking about? Okay, so the yolk stalk is here, it comes off the small intestine. This other thing right here, this is going to be your bladder eventually, right here. Coming off the top of the bladder is this structure right here called the urachus. Urachus. Remember where we heard the urachus? It was coming up inside your belly button? There it is. Okay? Urachus. All right. These other terms here, and by the way, the embryology of this stuff, I don't really care that you know this, but as far as for the test, but I'm presenting it to you so you'll understand the definitive structures. I'm not going to ask you questions about, you know, how this stuff folds. I will ask you questions about the ventral mesentery and the dorsal mesentery, but not about how it got there. All right, so now here's the thing. Here's what the string I've got going on here. Here's the foregut in green. And so here is the intestines out here in yellow. Okay? Now, the way you get all your guts inside of you is there's a folding process that goes on. All right? So, normally, everything is pointing straight, you know, everything's straight up and down. But in order to do that, things are going to have to rotate to get back in. Now, I will tell you that, let me back up one slide. I forgot to mention one thing. If we come out, here's the stomach. This is the gut tube. The liver is not the gut tube. The liver is a diverticulum off of the gut tube. The thing here that contains the ventral mesentery is the stomach. That's the ventral mesentery. It just so happens the liver is growing into it. And the ventral mesentery stays connected to the anterior abdominal wall. Those pieces and parts are called this. From the stomach to the liver that piece of mesentery has a specific name. It's called the lesser omentum. And the part that comes off the stomach is called the hepatogastric ligament. The part that comes off of the duodenum, which is where these ducts come off of, by the way, is called the hepatoduodenal ligament. They're horrendous names for something that's so flippin' simple. It's the continuation of the ventral mesentery. If it connects the liver to the stomach, it's hepatogastric. If it connects the liver to the duodenum, hepatoduodenum. Together, they're called the lesser omentum. And on the other side of the liver, it continues as the falciform ligament. Whoa, look this. What's in the free edge of the falciform ligament? That right there. The umbilical vein is in the free edge of the falciform ligament. The falciform ligament is the ventral mesentery, right, of the foregut. You follow me, Blair? You look a little confused.
You're talking way faster than I can keep up.
All right, here, that blue thing or purple thing right there is the umbilical vein. Umbilical vein carries oxygenated blood to the fetus. It runs across there and is in the free edge of the falciform ligament. If I ask you what the falciform ligament was, you'd say it's the ventral mesentery. You're going to see these in adults here in just a minute, and it's going to make sense to you. Am I right, Larry?
Yes, sir.
It's going to make sense. Okay, he knows what's coming. All right, let's go to the next page. All right, so here we go. Here's our stomach, our foregut. Here's our intestines right here. First of all, what we're going to do is we're going to rotate the small bowel 90 degrees. 90 degrees. So instead of up and down, now it's horizontal, like in B. You see, it went from that to that. Now here's what we're going to do. This is in this hand here is my colon, and this hand here is my intestine, my small bowel. What I'm going to do is I'm going to take my colon and I'm just going to wrap it above this, like that. That's all I'm going to do. I'm going to take, so I've rotated it to 90 degrees. Then what I'm going to do is rotate it another 180 degrees over top of it, and I'm going to pull it in there like that. So what I've got now, and then in order to get it back in there, my stomach has to lay down flat. Okay? I'll do it again. There you go, like that. I'm going to rotate it 90 degrees. What's in this hand is colon. What's in this hand is small bowel. I'm going to take my colon and just rotate it another 180 degrees and take my small bowel and just knot it up and put it in there like that. That's your gut rotation. And my stomach, by doing that, will lie down flat. And that's how it works. It's so simple. When you were a little bitty fetus, your GI tract kept growing and growing and growing and growing. And only about the 6th week, you finally said, wait a minute, you've got too much. You've got to pull it back in. And that's what happens. Your GI tract starts getting pulled back in, but in so doing, it has to fold to do so, and it undergoes 270 degrees of rotation. So you wind up with, here's our stomach lying down flat. Here's the small bowel here that dumps into the ascending colon, transverse colon, descending colon. And that's how it works. Kind of cool, huh? I'll show you, I'll take this to lab, and you can play with it on each other if you want. It's very easy. It's just, you take the large bowel and you just fold it over like that. So here's the ascending colon, transverse colon, descending colon. Works great. Or not. Sometimes that little yolk stalk right there doesn't degenerate. And what you wind up with is a connection between the small bowel and the umbilicus. Well, umbilicus, according to the BBC, if this acts like your appendix and gets inflamed, infected, full of toenails, whatever, it can become a problem. So a patient presenting with periumbilical pain, Meckel's diverticulum is something you always want to consider. So in the differential diagnosis of appendicitis, you always have to include Meckel's diverticulum. Some people, this actually is patent, and they have stool coming out their belly button, or their belly button will be wet. You know, it's mucus. I guarantee you, one person in this room has a wet belly. Is it you?
Yeah.
You in? No. Will have a wet belly button, and you never knew why. This is why. You need to have yourself checked out because you're gross. Okay? All right, anything else? Anybody else?
Is that usually recognized early, or?
No, not unless it's patent. It's usually found serendipitous. You know, we were doing a CAT scan of the abdomen or doing something that you found this by just, oh look, they've got a Meckel's. Of course, to fix them, you gotta go ahead and cut them out. So, this is when the GI tract does not pull back into the body cavity itself. You have GI intestines herniated through the umbilicus up into the placenta. This is called an omphalocele. Omphalocele, and you have to go in surgically and reduce that and seal off the hole. These are usually not lethal, they just require surgery in the immediate postnatal period. Not the same thing as an umbilical hernia that would develop later on in life. This is an omphalocele is a congenital defect.
You said it herniates through the umbilicus and then what else?
Yeah, I mean, when you were a little bitty baby, your umbilicus was continuous with the placenta. This is just into the placenta. Yeah. You didn't get an any until it clamped the placenta and it degenerated to give you your name. Okay. All right, so let's take another look at these membranes. Yes, ma'am.
Sorry. So what's the difference between a congenital umbilical hernia and an omphalocele? For those, because the slide on the umbilical hernias, it said a lot are congenital. So what's the difference between that and this?
You know the picture I showed you with the little baby with the protrusion? That protrusion is not intestines per se, okay? It could be fat, subcutaneous tissue. It's not intestine per se. Can be, but in an omphalocele, the abdominal wall is not patent. It's not really a hernia. It's the abdominal wall failed to close completely. I guess that's an easy way to explain it. All right, so here we go. Let's look at some of these mesenteries. Here's the posterior wall. Notice that as the stomach starts to lie down flat, that dorsal mesentery folds like that. It folds. And actually it folds so much that on the greater curvature, this is the greater curvature of the stomach, it actually hangs down. In an adult, it actually hangs down. So off of the greater curvature, you're going to see this fold of mesentery hang down. We'll see it in just a little bit. And realize that's dorsal mesentery coming off of the greater curvature. Ventral mesentery comes off of the lesser curvature of the stomach as it shows here. Now also keep in mind that as the stomach lays down like this, the stomach is like this, and I've got mesentery coming up to my liver. This is the ventral mesentery, right? This is the ventral mesentery. The hepatogastric, hepatoduodenal ligament. Right? Here's my liver up here. right there is a hole, is an opening. So here's the stomach, comes down and drains into the duodenum. Right around there is a hole, or is access behind the ventral mesentery. When you look in the cadaver today, you're gonna see the top of the stomach, you're gonna see the stomach line there. Coming up from the stomach, you're gonna see that lesser omentum, the ventral mesentery. Around the left side of it, or your left side of it, you can get your finger around it and get behind it. You can't put your finger back around the greater side, but you can the lesser side. You follow me? That opening right there on that side of the stomach is called the epiploic foramen. Epiploic foramen, way up at the top. It's what you're going to find on the patient's right side. Now, I'll just give you a little heads up. In the free margin of the lesser omentum right there, where you put your fingers around, in the free margin is where you will find what's called a portal triad. The hepatic artery, the portal vein, and the common bile duct. You don't need to write that down because I'll show it to you in just a second. But understand, at the free edge, right there at that epiploic foramen, you put your finger through there and push up, you're pushing against those three structures. All right? Now, if you stick your finger behind there, it's going to go into this pouch here. That pouch is called the lesser sac. Also, because later on you lost the ventral mesentery to the mid and hindgut, but you maintained it to the rest of the gut, you maintained the dorsal mesentery to the mid and hindgut, right? So all of the mid and hindgut are connected by the dorsal mesentery to the back wall of the abdomen. That's called the root of the mesentery.
Can you say that one more time, please?
Yep. So if we go back to our previous picture here, the mid and hindgut lost the ventral mesentery, but they kept the dorsal mesentery. That dorsal mesentery condensed or coalesced into one spot. That's called the root of the mesentery. So while you can take your small bowel and jiggle them about, and pull them up and toss them in your hands like that, you can't take them all the way out because they're still connected through the root of the mesentery.
Is it just in the dorsal side? What side?
The root of the mesentery is the dorsal mesentery. And one other thing is that you see this here as it folds off the greater curvature of the stomach? Right there? If we look in the sagittal section, here's our stomach, here's the pleat coming off of the greater curvature. And ordinarily it would go down and back up to the dorsum, right? But as it flops down and keeps growing inferiorly, it fuses with the transverse colon. This part will fuse with the transverse colon. So as you follow it down off the greater omentum, it goes down, comes back up, fuses with the transverse colon, which in turn is connected by the dorsal mesentery to the posterior wall. This sheet hanging down is called the greater omentum. You'll see it in just a minute. Depending on how much fat your cadaver has, or you have, that greater omentum, you know, it's a storage place for fat, and it also helps protect the abdominal organs. Can be anywhere from paper thin to feet thick. All right. One other concept here I've got to throw out to you is the fact about where organs are located in the abdomen. If an organ is surrounded by visceral peritoneum, which is the same thing as the mesentery, right? The earlier mesentery in this drawing. We now call it visceral peritoneum. If the organ is surrounded on all sides by it, it's said to be intraperitoneal. If it's floating in the peritoneal cavity, in other words, it's intraperitoneal. And by the way, the peritoneal cavity is everything in black. You understand how it's formed. This is the lost ventral mesentery of the mid and hindgut to form that cavity. All right. Some organs, though, they started out like this, and then as the folding occurred, they got pressed up against the back wall of the abdomen, and the mesentery fused with the back wall. Parts of the colon are like this. So in other words, they're surrounded by the visceral peritoneum. However, they're attached not by a mesentery like this, but they're attached directly to the posterior wall. If they had a mesentery at one time and then lost it, they're called secondary retroperitoneal. A lot of your organs are secondary retroperitoneal. And finally, if an organ developed on the posterior abdominal wall and never had a mesentery, it's called a primary retroperitoneal. The aorta, the inferior vena cava, the kidneys, the ureters, they're all primary retroperitoneal. They never had a mesentery, never will. They develop behind the parietal peritoneum. They develop out here. This is good because if I want to reach your kidney, can you lean up for me? I can go in through right here and reach your kidney without ever having to open the peritoneal cavity, because your kidneys are retroperitoneal. You don't want to open the peritoneal cavity because of the risk of infection. It's hard to get rid of. And by removing the kidney posteriorly, you never have to enter it. So intraperitoneal and surrounded by peritoneum and suspended by a mesentery. Secondary retroperitoneal, it had a mesentery and lost it. Primary, never had one. All right. Here's the way it looks. We've opened up your abdominal wall that you painstakingly dissected on Friday. You've taken that off. And in order to take it off, you have to cut through the falciform ligament. This is the ventral mesentery connecting the liver to the anterior abdominal wall. And the free edge of the falciform ligament is a little rounded structure there. It's called the ligamentum teres. The ligamentum teres is the remnant of your umbilical vein in the free edge of the falciform ligament. Here's the stomach is here. Coming off of the this edge of the stomach is the sheet of the greater omentum. That's gonna come down, back up around, and attach to the transverse colon. So that sheet comes off of here, goes up, and attaches there. The transverse colon is in turn attached to the posterior abdominal wall by this structure called the transverse mesocolon. Right there. Here's the sheet, comes down, attaches to the transverse colon, that's attached to the posterior wall. All right, now in situ, as your organs are, here's the stomach here. The duodenum is going to leave this end of the stomach and go over to this side. It crosses all the way over to the other side, then gives rise to the jejunum, which gives rise to the ileum, which ends here at the ileocecal junction. The cecum is the first part of the colon. Then you have ascending colon, transverse colon, descending colon is back up next to the wall. The transverse colon is intraperitoneal. You see, it's flopping inside the peritoneum. The descending colon is hugging the wall back here. It is secondary retroperitoneal. You can't take your descending colon, at least the first part of it, and pull it off the wall. It's stuck to the, it adheres to the wall by the mesentery. But once you get down here at your sigmoid colon and rectum, it's suspended. Obviously it is, because it's got to accommodate your doo-doo. You need some flexibility there. Generally speaking, if you draw a line, like this yellow line, from the left hip up to the right shoulder, what's on this side of the line is jejunum, what's on this side of the line is ileum. There's actually a way you tell based on the vasculature, but it's really not relevant. And finally, when you're talking about the colon, there are two flexures. This one on this side, that one on that side. They're called the hepatic flexure and splenic flexure, respectively. If it's on the side with the liver, it's hepatic flexure, which is on the right. The splenic flexure is on the left. Here's the epiploic foramen right there. That's the free edge of the lesser omentum. There's the greater omentum there. Free edge of the lesser omentum. Now what you're going to do is you're going to go through the lesser omentum, because it's right about there. Right about there. You're going to find the first branch of unpaired arteries off of the aorta. That's called the celiac trunk. The celiac trunk has three main branches. The splenic artery, the left gastric, and the common hepatic. The splenic goes behind the stomach. And your spleen is going to be way back here in the back, way back down there. So the easiest way to find all of this stuff is to go find the spleen, find the splenic artery, and follow it back to the celiac. That's one easy way to find it. Now the interesting thing about the splenic artery, it's a big artery, it's about the size of your little finger. It's not straight, it's tortuous. It's like a corkscrew. It's really goofy looking. You'll know it when you see it. It's big, it's thick, and it's tortuous, and heads back towards the midline. coming off of the splenic are a couple of different branches. The ones supplying the fundus of the stomach are called the short gastrics. And then you'll have a branch that comes off, that goes down to supply the greater curvature of the stomach, called the left gastroepiploic. The left gastroepiploic. So you can see the left gastroepiploic right there.
What does it supply to stomach?
It supplies the left side of the greater curvature of the stomach. That's the left gastroepiploic. Now, the left gastric comes off of here and supplies the left side of the lesser curvature. And it has a branch called the esophageal branch that supplies right there at the distal esophagus. Easy to find. The left gastric just comes off and supplies the left side of the lesser curvature. Now, the hepatic artery, the common hepatic artery, comes over and divides into two large arteries. One going down, that's called the gastroduodenal, artery, and that remaining is called the hepatic proper artery. So common hepatic gives rise to the gastroduodenal and the proper hepatic. The proper hepatic divides into a right and left hepatic. And off of the right hepatic, you're going to find the cystic artery that goes to supply the gallbladder. I know I said that fast, but you just follow the vessels out.
And we'll be able to find most of these.
You'll find all of them. All right, now also, off of the proper hepatic, you're going to get the right gastric that supplies the right side of the lesser curvature, and they get anastomosis with the left.
Say that again.
Off of the proper hepatic, you're going to get the right gastric that supplies the right side of the lesser curvature. It supplies us with anastomosis with the left gastric. You'll also have, coming off of the gastroduodenal, the right gastroepiploic that goes along the greater curvature and will anastomose with its counterpart coming from the splenic artery. So the lesser and greater curvature of the stomach are supplied from two different directions on both sides. Now there are a bunch of little arteries right here. The pancreaticoduodenal, the supraduodenal. I don't care that you find those. Understand, this is the point I want you to understand though. One of the points I want you to understand is that the foregut stops right there. So all of this stuff here is foregut. Oh, let's talk about the autonomic nervous system. To the GI tract. The vagus provides the parasympathetics to the entire GI tract, all the way down to the splenic flexure of the colon. So the splenic flexure is from here to your anus, so that's like 1.5 feet. Your vagus supplies 29 feet of it. You have the right and left vagal trunks in the neck that make a plexus around the esophagus. We saw that the other day. They coalesce into an anterior and posterior vagal trunk that goes through the diaphragm. You'll probably be able to see that today because the anterior vagal trunk is right there on the anterior surface of the stomach. It's very obvious. And the reason I can tell those apart is if you're going to scratch a butt, you scratch it like that, right? So posterior vagal trunk comes from the right vagus. When you wake up in the morning, you might want to turn. Can you turn that around? Just turn around. Turn around. Yeah, so you're scratching your junk in the morning, you're scratching your butt. Your left vagus is the anterior vagal trunk, your right vagus is posterior. Now you can turn it back around. See that? All right, got that? Bradley knows what I'm talking about. Now, it's preganglionic, all the way down. Where's the postganglionic?
On the organ.
Right, it's at, on, near, or within the organ itself. And that's exactly what happened. These preganglionics, they'll catch a rod on a blood vessel and go to the organ. So, if this is an organ, right, that's a small valve, it has layers of muscle fibers. Some run this way, some are circular, right? The postganglionics are situated between those muscle layers. So when you're talking about the small bowel or the colon, the parasympathetic postganglionics are in the organs themselves. All the way down to the splenic flexure. So the vagus is what provides the parasympathetics to the entire foregut, the entire midgut. It doesn't get the hindgut. The hindgut is picked up by S234. So we know that the parasympathetics are craniosacral. I've used that term, craniosacral. The sympathetics are from T1 to L2. They're in the middle part of the spinal cord, right? So the vagus gets all the way down to the splenic flexure. What gets the descending colon, your sigmoid colon and rectum, are preganglionic parasympathetic coming from S234. Now these are controlled. Understand, they just don't sit down in your sacral spinal cord and just click away. They're controlled by inputs coming from your brain. They exit the nervous system down here through the ventral primary rami of S234. And in this illustration right here, you see the ventral primary rami right there, coming out the sacrum, S234. And there are the parasympathetics associated with them. They're not connected to the sympathetic chain. These are parasympathetics. They come directly off the ventral primary ramus there. It's S234. Now, if they're going to a pelvic organ, they just go right over to the pelvic organ, catch a ride on a blood vessel to the pelvic organ. If they're going to go to the descending colon, they're coming out of your sacrum. They got to get back up to your descending colon. The way they do that is, if you follow in front of the aorta, remember we were talking about the ganglionated plexus, for the sympathetic? These guys are going to use them. The continuation of the preaortic plexus into the pelvis are called hypogastric nerves. That's the continuation of the preaortic plexus into the pelvis. We're going to see that tomorrow in lab. You can find the hypogastric nerves. They're huge. The amount of autonomics here. What we're going to do is we're going to catch a ride on those hypogastric nerves and just come out of the pelvis, catch a ride on since I said this was the hindgut, the artery of the hindgut is the inferior mesenteric artery. We'll just catch a ride on the inferior mesenteric artery to go to the descending colon, sigmoid colon, and rectum. In those structures, we'll find the postganglionic cell body. There you go. So, you had lunch, you want to defecate, you got the urge, You feel that it's in your rectal vault, you're ready to go, right? You need to stimulate your parasympathetics in order to make it happen. Your brain is telling S234 to let her rip, okay? These impulses come out of here, go up the hypogastric nerve, down the inferior mesenteric artery, into the descending colon, rectum, and sigmoid colon. They land on these nerves right here. These guys stimulate the muscle, and that's how you poo-poo.
Sounds like a little.
It's not quite that simple, but that's close. Because there's this sphincter thing got going on down there. We'll learn about the next test block. Yes,
Sorry,
ma'am.
what muscles did you say it was between?
They're in your colon. You have inner circular muscles that are arranged this way, and outer longitudinal muscles. So if we were to take a cross section, you're going to get them in cross section, right? They're between these two muscle layers. Back when you were a little bitty embryo, about 3 weeks old or so, you remember when we were talking about the dorsum, how it folds to give you the spinal cord, right? Remember, and then you got an open neuropore in the front would be anencephaly, an open neuropore in the back would be spina bifida, right? Well, your nervous system comes from your skin. It comes from the same cell line. It doesn't come from your skin. It comes from the same cell line. Ectoderm. That's what your skin's made of. That's what your nervous system is made of. When you were a little bitty embryo, pieces of that ectoderm broke off or budded off and migrated in there. That's how those cells, those neurons got there. They migrated from your back into your intestines. There is a disease or a condition. It's called aganglionic megacolon, or Hirschsprung's disease. What this condition is these neurons, these postganglionic parasympathetic neurons from S234 failed to migrate. So you have no neurons between the walls of the hindgut. Therefore, these newborns can't poop. And if you don't fix it, they'll be dead in a day. That's why a newborn, one of the things you do is you put a timer on when they have their first poop. Especially if this Hirschsprung's disease is particularly prevalent in the Jewish population. I'm not sure which type, Mediterranean Jewish population, something like that. I don't think it's Hasidic or something. It's a Jewish population. The way you fix it is you have to go in and surgically resect the colon. They start at the lowest part and take out a section, look at it under a microscope, and look for those neurons. If they don't see the neurons, they take more out. And they just keep cutting more and more colon out until these neurons start showing up between these layers of muscle. Then they take that and anastomose it with the bottom. The colon, if you Google images of aganglionic megacolon, because it's just huge. Okay?
What are those layers of muscle called?
inner circular, outer longitudinal. The neurons in there is called Arabax plexus, in case you're in jeopardy. Here's something kind of interesting. You have more neurons in your GI tract than you have in your brain. The GI tract can function independently. It doesn't need your brain to tell you the truth. It's called the enteric nervous system. And it's essentially its own nervous system. It just happens to be wired to your brain, so you have some control over it. You don't have any control over peristalsis, or liver secretion, or gallbladder emptying, stuff like that. It runs by itself. Okay. Let's do sympathetics, and we'll take a break. Sympathetics are kind of easy because you've already dissected them. Up in the thorax here, you've got the greater or lesser or least splanchnic nerve. By the word, splanchnic means predominantly preganglionic. So the greater, lesser, and least thoracic splanchnic nerve, they pierce the diaphragm here, and they're going to find their postganglionic not at or near the muscle, the organ like that, but in the preaortic plexus, the ganglionated plexus. Everywhere there's an artery that comes off the aorta, there's a ganglion. There's going to be synapses there, and those postganglionics are just going to ride the arteries out to the organs. The ganglion that's associated with the celiac trunk or the foregut is called the celiac ganglion. And it's huge. It's the largest one. And that's basically how you get sympathetics to the GI tract. Here's the celiac trunk. You'll have these two flattened grayish structures about the size of a quarter sitting on either side of it with all these fibers going in and out of it. Those are the celiac ganglia. The postganglionics going to the foregut are coming out of that. And as I said, as you go down the aorta, you have all these little ganglia associated with each artery. You have renal ganglia, you have superior mesenteric ganglia, you have inferior mesenteric ganglia. So they're going to be containing the postganglionic sympathetic. They're going to whatever that artery is supplying. Parasympathetic speed up digestion. Sympathetic slow it down. Take a break. So, oh, yes, ma'am.
I was going to ask if the enteric nervous system is on its own, kind of its own thing, and you said peristalsis in particular, then why does digestion slow down with sympathetic?
No, it can be on its own. You can denervate the GI tract and will function fine. But yours is not denervated. Yours is still under autonomic control from the hypothalamus. But you can transplant a kidney. You can transplant a liver. You can transplant a pancreas. It works just fine. Okay. All right, so take a break and we'll come back.
Well,
Can you stop that?